All right, so we are live now. Welcome everyone. This is our first live event for World Delirium Awareness Day 2021. This year we really wanted to focus on moving the evidence we have to prevent and reduce the harms associated with delirium into practice. Implementation is extremely challenging work, and we have a number of live, which is one of these, and pre-recorded sessions on this topic that will be available on the iDelirium YouTube channel. Full disclosure, this session is also being recorded and will be uploaded to YouTube afterwards. My name is Heidi Lindroth. My vision is a world without delirium. I pretty much do anything I can to move that needle towards that goal, and I'll be your moderator today. I'm a nurse scientist at Mayo Clinic in Rochester, Minnesota, and I'm joined today by a lot of experts. Here we have Brianna Walpole, Tru Byrnes. We also have Jim Rudolph and Gideon Kaplan joined us. And what we'll do is some brief introductions, and then I'll talk a little bit about the format of today's presentation and live event. So Tru, do you want to go first?
You're muted, Tru.
Sorry about that. So my name is Tru Byrnes. I work at Atrium Health, and see if I can share the screen. All right. Are you able to see my screen?
We can see your screen.
Okay. Sorry. Trying to. All right. So I work at Atrium Health in North Carolina, Charlotte. I am a geriatric clinical nurse leader and a niche coordinator for Atrium for Carolina Medical Center and Mercy, so both hospitals combined. It's referred to as central divisions. I have been a nurse there for 13 years. My background mainly in medical surgical, and then 2 years ago I had a opportunity to took over the geriatric, which I love. And my goal is just improving delirium in hospitalized older adults in non-ICU area. So.
Excellent.
So 2 years ago, I was on.
Hold on, hey, Tru.
Yeah.
Hold on, I'm going to have, before you start presenting, I'm going to have Brie and Gideon and Jim introduce themselves too.
Oh, okay.
Okay. Brie, do you want to go ahead?
Thanks, Heidi. I'm Brie Walpole. So I am an occupational therapist by background, and I'm currently working in Melbourne at Monash Health. So we are the largest public health service in Victoria. And my role sounds very fancy. It's cognition clinical lead. So it's really around that upskilling and implementation across the health network to kind of recognize and manage delirium. And I guess my goal is non-pharmacological management to improve, prevent, and manage delirium, because I guess that's my area of expertise and with my background in occupational therapy. So really focusing on the environment and engaging patients in meaningful activities while they're with us.
Awesome. Thank you. Thank you both for joining today and being willing to share your journeys and your successes with us. Gideon, do you want to go next?
Hello, I'm Gideon Kaplan. I'm a geriatrician in Sydney, Australia, and calling to you down under where it's morning here. And we've just started World Delirium Awareness Day. Keen supporters. We're part of the Australasian Delirium Association, and we want to give a plug. For those of you who want to join our conference, we're planning a live in-lecture theatre conference on September 8th to 10th, 2021, the first live to person delirium conference for 2 years, I reckon. So for all those people who are hungry to get to a conference, put that in your diary, and we'd love to see you at our conference. We realize not everyone from overseas will be able to come, but we hope this is the start of many great delirium conferences where we can join together as comrades, as brethren, as soldiers in the fight against delirium. Good luck.
Wonderful. Agreed. very jealous that you're having an in-person conference. So that's wonderful. And thank you for joining us. And Jim, I see we have like shirts on.
Yeah, we do, Heidi.
Wow.
Great minds dress alike on World
I
Delirium
guess
Awareness
so.
Day. So good morning, good evening, everyone. I'm Jim Rudolph. I'm a geriatrician and palliative care physician. I'm based out of Providence, Rhode Island. Right now, my parents have been both vaccinated. So I took a trip to see them for the first time in a year and a half. So the parent over my shoulder is my father, and we'll be watching on. So thanks, everyone.
Thanks for joining. And I see we have a few other people on the call too, which is great. I don't know, I see Sarah's iPhone and I see Shibley, and I don't know who the 609-316 is. But if you want to introduce yourselves, you can, since we're a small group. Otherwise, we'll continue on with our format.
Yeah, I'm Shibley. Continue, Heidi.
Okay. All right. Thanks for joining.
Thank you.
So the idea behind the delirium programming this year, it's super informal. It's really like a grassroots. Jim and Gideon are both founders of iDelirium. And so like this year, we really just wanted to have a grassroots. We all get together. We have open conversations about what's been done, all the great work that's been done so far, how we can get it into practice, and how we can move forward and work on reducing that mortality rate that we haven't budgeted in 30 years, as Gideon shared in his YouTube video. And so, given that the informal format, I think Tru's going to present first. It's an open dialogue, so if you have questions, feel free to raise your hand, put it in the chat. Then Brie will present, and we'll just have an open discussion about what they're presenting. Jim has a lot of system level VA experience with implementation that I know Brie and Tru are really eager to hear about too. So we'll just have an open conversation. And that's it. So it's free for all. Tru, if you want to go ahead and present.
Sure, I would love to. And thank you for allowing me to be here to share my delirium program that we have here at our hospital. So just a little bit about the background and how I got to this point. About 2 years ago, I started, got really interested in wanting to reduce delirium in older adults. So, and the question was like, I am a nurse, but then I talked to my colleagues and nurses, they don't really understand the delirium and how to assess and all that. So I started the groundwork about 2 years ago doing education nursing. Took 1 year for doing the unit education. And then the year after, in 2019, I started doing hospital-wide education for nurses. So for both hospitals. So we have to develop delirium modules, and basically it's an online module to educate nurses. And once that's done, then I get a group of multidisciplinary, so physicians, geriatricians. I had occupational therapists, physical therapists, and IAS, which is informatic, and clinical nurse specialists. All together, we came up with a risk stratification tool. So we created this tool after I went to American Delirium Society, and I learned from there and took what I got and came back to our hospital and created this tool, because apparently it's not something that I can take and easily replicate. So we have to basically create it from a groundwork. And so each of us came together, and we was like, all right, so there's this group of patients. How do we know which one is a higher risk, so we can focus our energy on these people, because our system is pretty big, and we have about 25,000 geriatric patients a year that came through our system. So 1 every 3 patients is age 65 and older. So we have a lot. So pretty much so we start creating this delirium risk stratification tool to identify who's at risk, at a higher risk actually, for developing delirium. And so the tool consists of about 37 risk factors. So that include predisposing factor, precipitating factor. So any patient age 65 and older. And initially, the list was pretty long. And I actually look at different patient population, medical, surgical, and neurology. And I include, if they are 65, they are at higher risk, but then that trigger all the patient on the unit, 80% of the patient will fall under high risk. That would not work for the nurses, because we want to identify those who at the higher risk, so we can implement intervention, non-pharmacological interventions. So we went back to the drawing and was like, okay, let's narrow the list down. And our delirium risk factor right now included about 37 risk factors. So every day I pretty much go in and audit all patients age 65 and older, and I score them by point. So if they have the certain risk factor, for example, age 70, they will get 1 point. If they have dementia, that added another point. If they have anticholinergic medications on the list, that will be another point. If they have abnormal lab values that within prescribed in our list, like for example, if they have albumin below 18, so they will have another point. So those are point. So the maximum point I think about 17. But if they have 4 or greater, that will consider high risk. So for those at high risk, what we did was we developed a non-pharmacological nursing protocol, a bundle, and this basically on a piece of paper, and we'll tell nurses this is what you need to do. And those are pretty much its literature, and like mobilize the patient, making sure they have the hearing aid, making sure that they have their get them up and walking. So those things, and then also that will flag the staff who came into the room, know that this patient is high risk. So that serve couple purpose, that to let the staff identify who are this patient, and then letting everyone know that this patient is high risk. And then I spend an extensive amount of time educating the patient and patient family, what they need to do for their family. And we also have family education that embedded within what we call is interactive patient care system. So is that implemented from the TV, because for our older geriatric patient, it's hard for them to see if you print it on a small print. So this way is play on that TV so they can hear it. So it serves a few purposes. So we have the education, we have the nursing protocol. Now for patient who's delirious, we'll have our geriatrician last year developed the treatment protocol, and that got embedded into the system. So within a year, we got a lot done. We had the delirium nursing intervention, non-pharmacological. We had the delirium treatment for provider who are not geriatrics, to help them guide how to treat delirium and treat and manage delirium. And then we had the delirium educations for family, and that of course got approved by the health literacy of the hospital to use. So we got that embedded into the the interactive patient care system. And that's also helped decrease the cost of having to print all these education for the pamphlet to hand the patient, because they can actually, when they go home, they can go back to their chart and able to pull this education and watch it at home as well. So, so I talk about the delirium protocol. I'll talk about the high-risk medication. So what I do is when I see patients that have high risk and who are delirious and have high-risk medication, what I would do is I call providers to ask them remove this medication, or can you possibly modify or change. And I would sometimes suggest to, instead of order this medication, can you order this medication? And most of the time, our provider really open to that. And then I also have a Delirium Toolbox, which consists of different games and toys and eyeglasses, books, and for patients that needed something to do. So those are extra for them. So for example, patient who has positive CAM, and this patient came in, they didn't develop delirium, and they actually developed in the hospital, and I really do a deep dive into their chart to see what's going on. Did we miss something? So for example, a patient who was very delirious, and I keep looking and I found that this patient had a positive urine culture. However, his team forgot to order antibiotic for him, and the antibiotic that he was on wasn't treating this particular bug. So I just talked to providers, say, hey, can you take a look at his urine culture? So like those things that I would really deep dive into the patient chart and looking at to see why, and then really talking to the staff and the family, making sure that this patient get up and out of bed, walking. And then we have consultation services, geriatrics, psychiatry, neurology, and these are service provided for, or actually not provided, but typically our surgery will consult one of these consultation service to treat the patient with delirium. So in addition to that, we have a variety of different types of service to help delirious patients. So with the high, and this is the data for 3 months after the implementation of the risk stratification. We have a reduction of 1.7 day in length of stay. We increased the detection rate by 50%. So yearly, this unit, we average four patients, so 46 patients. Since I started the project, we were able to identify patient more, but then we'll be able to reduce the length of stay because we had identified this patient earlier. So typically, once we identify this patient who had delirium, we look at to see why. So we were able to reduce their delirium severity. So typically it's about 2 days if they actually have delirium. And then we're able to see the post-discharge to skilled nursing facility decreased by 18%. So this project is still going, and actually I just finished my 6-month data, and the length of stay is very impressive, even better than the 1.7 days. And the detection rate, a little bit less, but it's still higher than before this project. Still the decrease to facility, we're still pretty low, like 27% decrease. So just this project alone is saving about over $400,000 in length of stay. So the next steps is that this risk stratification tool, I start created to by hand, and I'm going to disseminate it throughout trying to disseminate throughout hospital system. Before, well, I'll take that back. I'm trying to embed it into electronic record, because that will cut down a lot of my time doing chart audit and go and do the scoring every day. So I'm trying to embed it into electronic record. However, that's going to take another year or two. So at the meantime, what I'm trying to do is trying to pass on this hand tool to our nurses so they can do a project for the clinical advancement project. So that means that they can use it as their project and become an RN2 or RN3. Each person will do a different interventions, but the outcome will be still reduction in delirium incidence or increased detection rate. So the different bucket of nursing non-pharmacological interventions that nurses can focus on to use for their project. So the biggest challenge is time. This is very time consuming, trying to identify patients who are high risk. So for example, so daily I look through about 16 patients on this medical surgical unit, and I go through the chart and look at the history, look at their physical therapy, case management, medication, lab values, and give a score. So it's very time intensive. Yeah. So trying to how I'm going to be able to sustain this project moving forward is trying to get it implemented into electronic health record.
Wow. Wow, this is very, very impressive outcomes. I think Jim had a question for you.
Sure.
So thanks, Tru, and you just highlighted my question. Actually, is this is very Tru dependent, and so thank you for your hard work on it. We went through something similar, and we really struggled with our delirium risk identification. It was integration into the medical record that helped us, but we still found that we needed to sustain a lot of the intervention components, and then ultimately build a relationship with leadership to support it as a measurement tool before it began to really be sustainable without. And the sooner you can engage with your medical record folk, the better off. What medical record are you running?
So currently we are under Cerner. However, we are transitioned to Epic. And so we will have Epic implementations as we speak, but because Atrium is a little bit bigger, so going to take a little bit longer to go live at our hospital. So right now, my chief nurse, he's fully supportive of my project, and I presented to him. And of course, data speaks louder than anything else. And it took me a year to finally gather all the data, delirium, the length of stay. And it was like, OMG, the length of stay for delirium is three times longer than typical patients. And so I had that done, and I actually presented to the executive leadership team last month about the outcomes of this project and how I want this to sustain. So right now I have people helping me navigating our system, trying to implement this and sustaining this project. Now, even if we get the risk stratification and identify prediction into the system, the the thing that we'll need to sustain is to have a champion round on these patients to ensure that these non-pharmacological interventions are being implemented, because that's what is gonna make a difference. Just like fall risk, we know these patients they're fall risk, but nobody do anything follow up on it. Patient go into fall, just like this delirium. We can identify those at high risk, but then what's next? Who is going to follow up with this patient? So we have to have a plan to see, after this thing embedded, we identify who's at high risk, and now what do we need to do? I am the one doing the champion for right now, but by myself, I cannot oversee 40 units. So that's going to be the challenge. So I am going to, that's why I have the geriatric resource nurse who will help me become a champion, and I will train them how to look and what they need to do.
Well,
So
if I could say something, Tru, and that is, you certainly earned your delirium superhero cape.
Yeah,
Congratulations.
absolutely. Wow.
thank you. I still got a lot of work to do.
Yeah. How on the unit that you're focusing on right now, how do you engage the nurses?
So I typically what I do is, these are the nurses that I know them very well. I have worked with them for over 10 years. And when I go on this unit, I say, hi, how are you? I am rounding on this patient. This patient has been identified as a high risk for delirium. How Mr. S doing? Does he have any altered mental status? And so they was just engaged in talking. And then I look at the medication. I say, hey, this medication is high risk for delirium or confusion. Are you comfortable talking to provider to get this change? And if they are, then I'll let them, but that also giving them an opportunity to learn.
Mm-hmm.
So next time they see it, they will advocate for their patient. So like today, I wasn't at the hospital, but I got a text from one of the nurses on the unit, say, hey, they order hydroxyzine for this patient, and I think my patient is become delirious. What do I need to do? So they know me very well, and basically even providers, sometimes I just tell them, I say, hey, there's a delirium treatment there. You can use that. That will help you guide you to treat this patient. And so there's so many cases that I roll up and I send it to my my leader to basically make the case. This is what I do. And I have one instance, the provider ordered 25 milligram of Zyprexa. A starting dose of 25 milligrams of Zyprexa. Like, are you trying to kill this patient? So, but anyway, I just like professionally texted, hey, thank you for addressing and removing Ativan and adding Zyprexa. But I think that this dose is very high. Do you want to start this dose? It's typically 2.5 milligram. So.
Wow. Wow. I think, so we have a whole hour left, and Brie is going to present as well. And I know Jim was going to talk about system level implementation. So are there any other questions for Tru before we move on to Brie's presentation? That was really amazing work. Thank you, Tru, for sharing.
Thank you.
Not so much
Heidi,
a question, but
Heidi,
I think it's
Shibley had a comment too. Oh, sorry, Gideon, go ahead.
Yeah, not so much a question, but I think Tru's going exactly the right way about it by trying to incorporate it into the EMR, and this could be automated and provide alerts to all nursing staff and indeed medical staff about patients being high risk for delirium, and therefore paying special attention to screening them for delirium. So I think this, it's a real potential game changer to have the EMR notify about delirium risk, the way the EMR notifies about kidney injury risk and other risks. It would be great for the EMR to notify people, that patients are at risk of delirium and trigger them to screen for it.
I agree. If I may say something very quickly, I think delirium risk stratification is very similar to where stroke was, and with ABCD2. And I think we'll get to the stage one day where recurrent stroke, recurrent delirium will be seen as a major risk for stroke, for dementia rather, and we'll have a direct parallel with clinicians seeing people at the front door stratifying risk. Now, I would like to also mention from the research point of view that they all do not operate in silos. Now, Dr. Kaplan has just introduced with his colleague the functional imaging of delirium, in which he mentioned the default mode network. Now, in fact, it is worth noting, Dr. Kaplan, that old age, young age, anticholinergic drugs all decrease the activity of the default mode network. In fact, a lot of the risk factors for the development of delirium directly reduce the activity of the default mode network. So therefore, what I should like research to do in future is to have a more rational-driven approach to risk. In other words, look at the neural substrates for operation of the default mode network, or even machine learning to look at the big data, looking at lots of data points about risk in future, but we're talking about 20, 30 years ahead now. That's it.
Thanks, Shibley, and that's we've done some, and what we have is that the data is only as good as the data. And some of those seeing people, and as we're talking to our colleagues, are things that don't always get transcribed into the data. And so it's been really wild to try and do this with data, and largely we end up with scales of frailty, and whether it's cognitive frailty, whether it's social frailty, whether it's overall physical frailty. They all kind of blend into one because they're all delirium risk factors. And it's great job security because we know that we're still needed to make.
Yeah, absolutely agree. Thank you for bringing that up. It's so important. And Gideon, I don't know if you wanted to say anything. I know you have to go.
Oh, I'd just say quickly that, look, big research is fantastic and big data can be a great tool. But for delirium, we also need to have very precise data and really characterize the participants in our studies very carefully and select the patients very carefully to identify, who has delirium, who has dementia, who has other comorbidities, who's on what medications, what other conditions they have, and to characterize the type of delirium they have, because delirium is not one entity, really. We see different types of delirium, which manifests in different ways with different phenomena. And, so we need to understand how all these things into play. So we need to really get a lot of information about individuals, which can't be just harvested from the medical records and make some beautiful big data set. We need beautiful small data as well as the big data.
Yeah, in relation to that, by the way, there is a different arm of medicine, personalized medicine. I've just come from the frontotemporal dementia group, and they're talking about gene typing tauopathies and other things. So it's quite possible in about 10, 20 years' time. Well, actually, this is very beyond resource scoping, but seeing particular types of dementia which are going to be accelerated by delirium in particular. And in fact, I felt that was alluded to in the previous talk.
That's right. We really don't know how delirium causes dementia, what the resultant dementia pathology is. And so we need to understand why delirium is such a huge risk factor for dementia, but we don't know how it works at all. There's a lot of stuff we need to know.
Job security again.
Absolutely. Good luck, everybody.
Thanks for joining. All right, and I know, Jim, you have to go soon as well. So do you want to talk about the implementation work you've done at a system level and how, like, we are challenges, strategies for success?
Sure, Heidi, and I won't be long. Brie, thanks for ceding the floor to me really quickly. And hello to Alasdair, nice shirt. So I work in the largest integrated health system in the United States. And the beauty is that we are 150 hospitals and cover about 7 to 8 million lives and provide integrated healthcare for that. The beauty or the hard part is we're 150 hospitals and we provide care for 8 million lives. So it's really complex in the sake of it. Well, what I would say is that along the lines of what Tru and Brie are doing is you start small. And you have to begin with what you have influence over and where you can make change. And if you're a frontline hospital physician or a geriatrician or a nurse or a custodial staff member who helps clean rooms, all of those have important roles in delirium. And you start with where you have influence so that you can help to build that momentum and that sphere of influence. Actually, no delirium programs have started because someone was walking into the CEO's office and saying, "You got a problem, and I'm here to solve it, and give me lots of money." It doesn't work that way. So we have to work clinically. One of the things Tru represented that she did very, very well is collect data. Even in small numbers, data really speaks. There is a wealth of evidence behind every delirium initiative so that you don't go in alone. So when Tru says she has a 1.5 day length of stay, you know what? I can find evidence to back that up, that it actually, you can actually save length of stay by preventing delirium. The evidence base is big enough to help support that. As you're building your program, remember, think grassroots, because those are the people that are most connected to the patients. And if you can't get it to work on a small scale in grassroots, it's never going to work on a big scale. At the same time, you're doing grassroots, you have to do that upward selling. And it's a skill set that we are not trained in, right? I'm not a salesperson. I'm a delirium guy who works in a hospital, and but you really need to learn that language and make that sale. Your passion will carry you far, but your data will bring you the rest of the way to build that support. And then over time, what I would say is, don't always ask for money. That it's great if you got a pool of money and things like that, but what's better is protected effort to allow you to pursue this passion, supplies, even through donations to help fill your delirium toolbox or whatever your system looks like. And as Tru demonstrated, more important is prioritization on the electronic medical record list. Right now, if Tru could actually save her health system $400,000 per year tomorrow if they would prioritize hers to the top of the list. And so a little selflessness can go a long way, and particularly in the sales process. If you're not out asking for something for yourself, if you're really trying to do this to improve the system, it can go a long way towards the selling. I will say that we have electronic delirium risk monitoring in 150 hospitals now, and we built in performance metrics to follow through on that. So I can tell you which hospitals are recognizing delirium on admission and which hospitals are not recognizing delirium on admission. And that changes the game too. So everyone, you know, small steps to begin with. We've all started there. And as I like to say at the ADS, I've given over 500 delirium lectures in my life. And I can tell you that I'm probably, if you judge my delirium lecturing abilities on the clinical change that's happened because of them, I'm probably the worst educator in the world. But you know, I keep the drumbeat going, and we make progress little bits at a time. And if all of us make little bits of progress, then slowly we'll move the needle forward. So thanks everyone for being here. Good to see everyone from around the world. This is awesome. And looking forward to learning more. We got 36 hours of delirium programming. Brew some coffee, folks. Brew some coffee.
Thank you so much for joining. Truly appreciate it. And it's an awesome perspective of like the grassroots, and like it's so easy to like, you just want to ask for money, you just want to ask for resources. I mean, that's huge. That's great advice. Thank you so much for that. Brie, I think you have been waiting to present. So if you want to share your screen and go for it. And again, just for the people who have joined, this is super informal format. We have about 45 minutes left. If you want to raise your hand, ask a question during the presentation, you absolutely can. You can put it in the chat box too. You can nudge me and text me and say, hey, I want to ask a question. That's fine too. And we'll go from there.
Thank you, Heidi. I think between Tru and Jim, they've kind of stolen half my talk. Like, I think I have a slide saying called Start Small, Scale Up. So definitely something I've learned over the last, 18 months at least. So I'm from Monash Health, so in Australia, in Melbourne, and we're Victoria's largest public health service. But after hearing about Jim's, the size of Jim's health service, we're tiny. So, we started this delirium kind of initiative, must have been nearly 5 years ago now, and it was really around that comprehensive multidisciplinary approach. And we wanted to include both clinical and non-clinical staff. And I think we've realized how key the environmental food and food services can be. The ward clerks, I think everyone has a really important part to play in this space. And, we've kind of wanted to include them from the start. It's really been around that education, screening, assessment and management, looking at resources and environmental considerations. So, and I think the whole intent of these conversations is around how we can make it sustainable. And, we've used that improvement science methodology originally, probably back in 2017, 2018. We had a really great set of resources, but probably didn't really focus on the implementation and how we can get that right. So we've now kind of pared it back and are starting again, I guess, now that we've updated everything, and obviously keeping patients and families involved from the beginning, from consultation and all throughout the process. So we have a consumer person who sits on our delirium and dementia and cognitive impairment steering committee. So we've always got someone there, and then we've got another committee that we can take patient information to and really kind of get that consumer feedback, as well as just asking patients and families on the ward in real time. So we're very lucky from that perspective. We have national standards. So Monash Health has actually been accredited in June this year. So it was meant to be June last year, but it was delayed. And it's the second edition. So this is our first time of going through the second edition of national standards, and previously delirium wasn't included in the first lot. So in some ways it's great, because now as a health service, we have to demonstrate how we're recognizing and preventing delirium, how we're recognizing and managing that acute deterioration, not just in physiological sense, but also psychological. So that includes delirium, and also how we're reducing our use of antipsychotics. So it's actually kind of really good for us, because it's given us this push. We were kind of working on it beforehand, but now we have these set of standards, so we actually have to show what we're doing in this space. So it's actually kind of helped drive the force a little bit more. So our framework and resources, we've developed a comprehensive guideline, so it's around delirium and dementia in hospital, and it just outlines everyone's roles and responsibilities, our timing for screening, our timing for assessment, all the non-pharmacological strategies, if you have to use pharmacological management, what should you use, when, etc. So like I said, I think we've got a really good evidence base of what should be done, and then it's really around implementing that. Our education and training and electronic medical records. So we've only transitioned to EMR in the last 18 months. So some of the data I'll show started on paper and then it's actually transitioned into medical records. So that's been a little bit of a challenge. And obviously my passion is around that non-pharmacological management. So we use 2 communication tools with Sunflower and Top 5. And then, you know, we've kind of developed a few other little bundles and patient and family information. So it's kind of the model there is the care of the confused, hospitalized older patient. And that's the framework that they kind of set up to make a change. So this is Ward H at our Casey Hospital. So this was World Delirium Awareness Day in 2019, and then I have one from 2020 as well. So this was to get, you know, everyone engaged and excited that we're kind of starting on this delirium journey on this ward. So they are a geriatric evaluation management unit. And in this picture, obviously you can see the delirium superheroes, but there's nurses, there's allied health, there's medical, and there's non-clinical staff there too. So to really try and drive that change, that it's kind of everybody's responsibility. And this is kind of where the data that I'm showing on the ward that we've been kind of working with. So start small and scale up. So people stealing my thunder, but you know, using that quality improvement methodology. So we have linked with Safer Care Victoria, who's the kind of quality improvement arm of our state, and they have partnered with the Institute of Healthcare Improvement. So using those PDSA cycles and scaling up that way and using the data to tell the story is kind of where we've begun. So we involved all key stakeholders from the start: patients, families, bedside clinicians, managers, executives, kind of anyone who wanted to listen or be involved or who had an idea. So this was, you know, this was our paper and pen based ideas board around, you know, what our current practice is, and then kind of how we really want best practice to look in the future, and then, you know, how we can get there. So we process mapped it out. And we were really visible and transparent around what we were doing. So we had a space on the ward that was visible to anyone who came past: patients, families, staff, visitors, contractors, anyone in between. And you could see what we were doing in real time. And there was also an ideas board where people could write ideas that they had that they could do in this space. What can we do to increase screening? How can we manage this better? How can we get on top of that? It would be great if we had, you know, more access to outside space. Could we get a table here so, you know, people can have a rest and sit on the corridor when they're kind of mobilizing around the ward. So it was, you know, a whole host of different things, but it was in that kind of one spot where people knew where to go. It was okay to fail. I think this is another kind of key learning aspect. So this was my brain cake from 2019. 2020 was a bit better. It was a cheesecake-based one. And then this year, I haven't actually uploaded and tweeted my pictures yet, but I just made little mini brain cakes, mainly because I lost my mold at World Delirium Awareness Day last year, and surprisingly I haven't needed to use my brain mold in the last 12 months. But I think the message we're getting across was not, you know, from tomorrow, it wasn't from tomorrow everyone has to be screened for delirium, and everyone has to have an individualized care plan, and everyone, you know, has to have this updated. It was actually really about starting small. Hey, let's trial this. Let's introduce the 4AP, which is the screening tool we use. Let's introduce that, and let's just try it on a few patients. Tell me what you thought about that. Oh, okay, it didn't work if you tried to do it in the morning shift. Let's try and do it in the PM shift when there's more family around. So it was that trial and error. So it wasn't kind of dictating that, you know, from tomorrow, we need to reduce our falls rate, we need to increase our delirium screening, we need to reduce length of stay. It was actually around, let's slowly build on this to really try and make it sustainable and engage the staff from the beginning to see what works for them. So they knew that if, you know, all they had to do was trial it, and if it didn't work, well, then we can go back to the drawing board. So I think kind of putting that message out that it was okay to fail, and we're going to see what works best for that ward environment, which will be different to, you know, an acute ward or to ICU or to the emergency department. You know, it's, yes, we have the same principles, but how's it going to work for them in their space? So I think that was one of the key kind of learning outcomes for me and for the team. So this is our Sunflower and Top 5. So these are our kind of getting to know you tools and our approach to individualizing care. So this is our Sunflower which, for example, we said that we want it to be completed on all patients who score 4 or more on the 4 AP. And, you know, the ward actually decided that this was just a really great getting to know you tool and getting to know our patients a little bit better and providing that person-centered care. So they completed it on all patients, regardless of their cognitive status, because they just think it was good to know little different things about them that they could engage when they were providing care. So, for example, you know, Elizabeth, she prefers to be called Betty, and just by knowing that's her preferred name can make a huge difference. And the top 5 is probably a lot more, for me, I think a lot more useful around how we can understand a patient's routines and preferences and try and incorporate that into the hospital setting as much as possible. And this is where, you know, that kind of conversation and communication with the family and the patient and getting the family involved is essential. So, you know, knowing that Betty has a cup of Milo, which is hot chocolate because Milo is a very Australian thing, around 8 p.m. before getting ready for bed, and that she hates tea, is a great thing when, you know, she's in a room that doesn't have the best natural light, there's no large clock there, she's actually still in her pajamas all day because, you know, she doesn't have day clothes. If she gets that Milo at 8 p.m, well, then that's her routine. She knows that it's time to kind of start to settle to bed. So it's just those little things that, you know, it doesn't involve more staff. It doesn't involve a whole lot of money. It's actually just understanding a person as a person and understanding her as Betty instead of, you know, patient in bed 5. And it was just about trying to get staff and patients to think like that and think, oh, actually, I can do this in my everyday job. It's actually not extra work. It's just what I'm already doing. Up the top, we've recently just launched our new delirium education module. And so this is an online module, and we're really fortunate that Monash Health has kind of endorsed this as required training for all clinical staff. So that includes medical, allied health, nursing, and we've got another module for our non-clinical staff as well. And I think that, you know, that just highlights the importance that we're kind of putting on and, you know, want to emphasize in this space. So our senior medical staff and consultants are required to do this training too. So the uptake's been really good so far, and it's really tailored to what, you know, people's roles are and what they need to know and do in this space, as well as showing how comprehensive and multidisciplinary it needs to be. So that's really exciting, and that's something that's just kind of launched in the last couple of weeks. We did have a module prior to this that staff were doing. Our Delirium Pod, which has your one-stop shop of information on the ward. So there we've got our Delirium Toolboxes with those diversional activities in it that Tru was referring to as well. We have the patient information sheet, so staff know where to go to get an information around delirium in hospital and what patients can do and family can do to assist and how you kind of start that conversation. There's an environmental checklist, so are the blinds open during the day? Is their call bell within reach? Is the room set up appropriately? Is this the best place for the person to be? And, you know, are your hearing aids and glasses in and working? So everyone knows where to go for that information, and that's kind of available on the ward. And this is our quality improvement or delirium board that I was talking about previously, that everyone can go there, they can write their ideas, they can, you know, it's got updates of the data and how the ward's going. Like I said, Ward H has done their own Sunflower tool, so their interests are delirium and people important to them and the patients and families. So it's really kind of just, you know, taken a little bit of a fun approach to it to really change the vibe and culture of the ward and to have that kind of, oh, actually I can do something about this. I think people go, oh, there's nothing I can do, you know, the same with falls. There's nothing I can do to prevent this person from falling, and, you know, there's nothing I can do to help this person's delirium or cognition. They're just confused. It's just the way it's going to be. They're going soon. And now I think people's approach is changing and thinking, actually, I can do something about this. I can actually prevent it before it gets to that level of escalation. So this is our data. So we actually started as a baseline of 0 because they weren't screening at all for cognitive impairment. And now we've managed to, it actually says within 24 hours, but we've changed that to within 8 hours, and we're still sitting around that kind of between 90 and 100% of screening for delirium is happening within 8 hours of admission to the ward, which is excellent. And like I said, this data is kind of goes up to the end of 2019, but I did have a look and it has continued on. So that's really exciting, that I think it shows that it has been sustained in practice and now it's just part of what you do. Our falls was quite high. So this is like the raw number of falls, but they have gone down. And I think the important thing to note is that there was no falls with harm or serious harm, and that's continued to stay that way. So I think that once again, it feels like staff actually can do something in terms of falls prevention, because we know if we can manage delirium, we'll be able to manage falls a lot better too, and pressure injuries. This is our average length of stay, which I think the same thing, it speaks volumes to the executive and management around how we're going in this space. But being a geriatric evaluation management unit, the length of stay is longer than an acute setting. But our average ended up around the 23-day mark, and that now it's around 20 days. So we can't say solely it's been because of our delirium initiative, but I think that it's definitely contributed. We're understanding patients' needs a lot sooner. We're putting in prevention strategies a lot quicker. We've got, you know, that delirium bundle of mobilization and hydration and nutrition and engagement in meaningful tasks a lot sooner. You know, that engagement in therapy, getting allied health involved, and it's definitely impacted our length of stay, which is, you know, which is good for the patient. So the sooner, you know, means the sooner they can go home, the less likely they are to experience harm from, you know, being in hospital. So percent of patients administer antipsychotic medicines. This is just to kind of give us a little bit of a snapshot, and this is where I think is still a bit of a gap in our approach, and we're definitely working on it. You can kind of see by the data in September, it's very, at that point in time, it was very person dependent. I was away on leave, our delirium champion was away on leave, as well as our kind of medical consultant, and also our junior medical staff rotated. So I think that just highlights that it was on a downward trend, and I think that just shows it's still person dependent and not quite process driven. But now that we've moved to electronic medical records, this has made a huge difference, because we have a delirium order set and we have our acute behavioural disturbance guideline built into our medical records, and it kind of says, are you sure you still want to do this? Is this appropriate? What's the timing? You know, what do the observations need to be? Are you still doing the non-pharmacological management? So I think it just makes people think twice about it. So I'll have to go back and have a look, but from the reports that I have from the ward, their use of antipsychotics have gone down, and we're building that dashboard at the moment. So similar to like Jim said, you'll be able to compare hospitals and wards independently of, has a screening been done, has a diagnosis of delirium occurred, has a care plan been initiated, and they're kind of done in little donuts, so we can break it down that way, as well as there's going to be a, which I have a meeting this afternoon around the use of antipsychotics, and looking at a care plan, from a dashboard from that perspective, which will look at, if they do have delirium, have they been administered an antipsychotic while in hospital? So there is work happening in there around that quality improvement and implementation, but I think it will be ongoing for a little while. And I guess this is what it comes down to, is that staff knowledge and patient experience. So I sang Elvis to my patient in the corridor last week, as it was identified in the sunflower tool, and that got my patient to walk. So this patient wasn't mobilizing, they weren't really engaged in therapy or in you know, bedside care, and then they found out that the patient really liked listening to Elvis music. So the nurse, the physio, and the OT played it on their phone, and the patient kind of got up and started to mobilize. So then while they did that, they're like, okay, quickly, let's walk a little bit further to the bathroom and let's do this, etc. But it was more the fact that they found out something that motivated the patient, and also the staff felt like they, you know, could do something to assist caring and looking after that patient. So that was a really good outcome there. You could tell that they're listening to mum's concerns and what mum likes, and treating her like Mary, not patient in bed 5. We took the sunflower tool home to help when carers visit. So that's what it's really about. I think these kind of stories and grabs really tell the story around the patient care and the patient experience, and that staff feel more confident and knowledgeable around how to care for our patients with a cognitive impairment. So that's just a little bit of a snapshot around what we've done here, and we now are looking at kind of looking at the spread and kind of trialing it in our general medical wards, and then hopefully, expand it throughout the health service. So I think baby steps and starting small and getting it embedded into practice is the way to go. So thank you.
Wow, that's excellent. Thank you so much for sharing. So before I have questions, but I'm going to give everyone else the opportunity to ask questions. So please ask questions. You can chat them too if you don't want to talk.
Yeah, I've got a couple of
You're more than
comments.
welcome to come to Australia. Shibley. You might just have to do 2 weeks hotel quarantine first.
Yes, it's can you hear me?
Yep.
Yeah, well, hello everybody. It's 10:30 here in Scotland, and I kind of missed the beginning because I was cycling home. As I thought it was going to take ages to do all the tweets for, so so far I've got up to 3 a.m. my time, so I still need to do a few more before I can safely go to bed, and then rush in tomorrow morning and try and make sure that I don't. It's like I'm being chased, by all these tweets that I have to advertise on Twitter. But there's been quite a few people who've viewed this, or viewed the YouTube things. So I think it's going to have a cumulative effect. But anyway, that's an amazing piece of work. I'm sorry I missed your presentation, Tru. I see it's being recorded, so
it is, and I'll upload it to YouTube
channel. So I'd love to catch up with that. And also Jim's been a warrior, in this field as well. But I suppose that'd be great to just ask Tru and Brie what the attitude of the sort of hospitals has been like. Is it been that this is now seen as a great thing, that we're quite good at delirium now in our hospitals, or is it seen as a pain in the neck? Like you're always haranguing people to sort of do better, or is it just becoming normal to sort of just care about delirium in a sort as if it's just any other important condition?
So I can go first. So for us, to be honest with you, before I started my delirium round, and it was kind of things like, okay, patient have delirium, patient confused, and so they just go on, people just go on with their days and not really pay attention to it. But now I feel like, at least on the unit that I am on, that staff start using the term delirium more, and more understanding, and they make effort to prevent it. As far as providers, it's just depending on with specialty. In medicine, when I talk to provider, internal medicine, and I say, what are you doing right now? I say, I'm doing delirium round. And it's like, oh gosh, bless your heart. This is, it's very challenging. So, but talking to a surgery resident, they're like, oh, okay, patient delirious, she's confused, and then move on. So it's just depending on who I talk to. Is it a pain? I don't think so. I think people just recognize that delirium is a condition that need to be recognized, but how do we want to prevent it? So trying to raise the awareness and say, hey, we can prevent this. Hey, we can do something to reduce the severity and get the patient back to their baseline. As far as the leaders in my organizations, I had the data to back up what I say, so they believe me. And 2 years ago, nobody looked at this, and nobody had the data. And I was trying to ask my leader, the assistant vice president, for the data and how to pull the data, extract the data, and nobody know how to do it. So it took me a little while to get all the data, the length of stay of all these together, and present it and make my case. And so they know the importance of reducing delirium now, and I get the buy-in from my executive leadership team. So
Great to
moving
hear.
forward is going to be a little bit harder because what I'm trying to implement at my hospital will impact other hospitals in our system.
Yeah. Yes. Where are you based?
I am in North Carolina, Charlotte.
Right. Yeah. Yeah. I mean, I think it's interesting to compare UK with Australia with the States, isn't it? I mean, well, Scotland is 5 million people, so it's just like a small region of the States, or, you know, part of a region of Australia, probably. I mean, we do have a UK-wide thing, which I suppose ends up being 70 million, which is comparable, I suppose. I mean, the NHS is 3 times the size of the VA, so it's probably the biggest unified healthcare system in the world in terms of having top-down management, and it's mostly a good thing, I would say, you know, because you know, I was really interested to hear Brett talk about standards, you know, because there was that article in Annals of Internal Medicine by Melissa Mattison that came out, a general review on delirium in 2020. And it was interesting that she was quoting what guidelines exist in the world for delirium. So there were only 4 that she mentioned: Scotland's ones, England's ones, Australian ones, and the ICU ATF or the PAD one, I think it's called. That was it. You know, so I wonder if United States needs a delirium guideline, you know, that, I mean, I don't know if that's possible in the United States. I mean, if there's some body of authority body that could kind of, because Australia's got this I mean, I presented when I went, first time I came to Australia, and it always hurts to talk about my visits to Australia when I can't, you know, it's stupid COVID, you know, has made it hard again, you know what I mean? You know, but anyway, that's another chat. But you know, the first time I had an amazing meeting with just a small meeting with some quite influential people, and just what's going on with delirium, and you know, they were already putting it together, but it's really had a big impact in Australia, I think, hasn't it? Because people have to do it. Do you know what I mean? That's the great thing about policy. It's no longer a choice, and that's what gets the senior managers involved.
Yeah.
Anyway, so I've maybe said too much, but whether it's done by state, you know, but so many states to deal with, it's a pain in the neck to go around every state.
Right.
I mean, so if you could just get a consortium of societies, you know, to agree on some kind of set of standards, you wonder would that have an effect? Would people care? I mean, because it's money driven, isn't it? It's not so much standards driven. So
yeah,
money driven. I mean, I think if it, go ahead.
I think the only thing that will change the way that make the people really, not people, I would say, but I think have policy change. CMS will not reimburse for the hospital acquired delirium, just like everything else, and that would make people change.
That's a huge thing, isn't it? Yeah, there's a structural thing in the naming, isn't it, that needs to change to encourage people to do it. Yeah. Anyway, sorry, but that's. I mean, Mark Oldham and I have talked a lot about this, and you know, there almost needs to be NIDAS or some body, the ADS needs to really go for that problem, because that's such a structural thing. I mean, no one's going to diagnose delirium if it costs the hospital money, you know, or it costs them money. Like if a psychiatrist is going to get paid $200 less for writing delirium versus encephalopathy, then they're not. I mean, most of them just aren't going to do it. You know what I mean? Because they have to pay the mortgage. I mean, it's an absurd situation. Anyway, sorry, I've said too much. Maybe I don't know what you think about the Australian position, because it's regional, isn't it? But it's a national approach as well.
Yeah. So the standards are national. So we get accredited on that every 3 years, regardless whether you're a public hospital or private hospital. You know, you could be a 10-bed hospital in the smallest country regional town in Australia, or you could be a big public health service with, you know, 5 campuses and 1,500 beds. So it doesn't matter. You have to demonstrate what you're doing regardless, which I think is really good. We were lucky that we were kind of starting to do some work in this space before the second iteration of the national standards came out, but absolutely, it just actually highlighted that now we have to. And the great thing is that we can speak to other health services around what they're doing, and we can benchmark, and we can not reinvent the wheel. So we're all on the same cause around trying to improve patient outcomes and reduce that harm. And in terms of money, the coded data, we actually want to increase the coded data, because if we code delirium, we get money for that. So for us at the moment, it's a win-win. When we start looking at hospital-acquired delirium, it'll be a little bit different, but it's not at that stage yet. But I assume it will come. But if we can show that we've done X, Y, and Z prior, then I don't think we'll be financially penalised for that.
Wow, yeah, it's very different than in the States, as we've said. But that's really what struck me, Brie, as you were sharing your screen about the national guidelines that you have. We just don't have that. So even Scotland, you have those guidelines that came out, Alasdair.
Yeah.
Was that last year or was that 2 years ago?
It was 2019, yes. So SIGN is the Scottish Intercollegiate Guidelines Network. So it is national, because the NHS in Scotland is run differently from the NHS in England, although we're quite aligned in most ways. There are some differences. And SIGN is, it's not adopted by England, but it's very influential, because we try and harmonise with the English system so that we're not doing the same guideline at the same time. That's why NICE was 2010. And so this was a way of making it like dovetail. And I think the NICE guidelines will be updated, and it will probably change. We know that they're going to change to the 4ET from the CAM, for example. So because and we did a survey showing that the CAM is falling away in the UK now, even though NICE is still recommending it, just because I think people have. So it will also influence it in terms of the drugs, because SIGN didn't specify a certain drug to be used or anything. NICE probably slightly over relied on evidence of a couple of small trials, and didn't really take into account. And one process that's different about SIGN and NICE is that SIGN allows expert consensus to be a bigger part of it. So you have something called good practice points, so delirium's full of things that aren't evidence-based. And in fact, if you read the SIGN guidelines, there's only one page on delirium treatment. There's a big chapter on drug treatment, which just says don't use drugs unless somebody is extremely distressed or in danger. But the multi-domain delirium treatment page, that's what delirium treatment is. That's most of the delirium work, is that. Isn't that funny? I always find that really weird that we talk so much about prevention and detection, but actually 80% of delirium, you can't prevent it. Because most of it arrives at the front door, at least half, 60% maybe. And in the remaining 40%, you can only prevent a third of it at best. So most of the job is delirium treatment, and most of it's this process of care to do with finding the causes, treating distress, all these things, which everybody in this call knows. But it's dead weird that people hardly, in review articles, it's barely mentioned, and we had a big session on it in the SIGN Guidelines Committee. I was the co-chair with AJ, AJ and Cairns, who you stole him from Scotland. We're old pals, but AJ Matthew is a psychiatrist who did loads of implementation work in Scotland, and we were old pals, old drinking buddies. And that's another reason, because he said, you can come and stay with me in Cairns when you come to Australia for 5 days, and I'll show you a great time. And that's been stolen from me again. It's so annoying. But anyway, so there was a lot of discussion about this, and we just came down to this 8 points of the things to consider in delirium treatment, and maybe some pathways, but at the moment it's just mostly just that good sense, good expert consensus, bringing together good sense. But some of the work I'm doing at the moment is trying to look at variability in delirium treatment. So when somebody gets a diagnosis, what happens in the next 2 days or 3 days? How much work is done to find the cause? Is distress looked for and helped? Is the family spoken to? Is that documented? You know, is there a risk assessment for pressure sores and falls and aspiration pneumonia? You know, all these things that because they're such vulnerable patients, and I think people also forget 1 in 6 of them die in 30 days. You know, and so they need exquisitely detailed care, don't they? So I find that all quite strange, but it's really inspiring to hear these other, you know, systems which are all have their different constraints and challenges. You know what I mean? But to try and get them to do better, because we're trying to put a strategy in place for my region, which is kind of about a fifth of Scotland, I suppose, so about 1.3 million people, and we've got we're putting together a strategy. So I'm listening really hard to what, you know, the stuff that you've learned and done, because we're slightly behind you. I mean, we do have quite good detection at the front door. You know, 75% of people get a 4ET, and about 15 to 20% are positive. So, but we don't really have reliable detection after admission. It's just chaos. You know, it's just which ward they're on, and you know, so there's a lot to be done there. My battery's about to go, so I need to go and find my charger. But anyway, I'm talking too much because I just love this subject so much, and I could spend the entire night talking about it. I can't wait to watch your presentation, Tru. I'm so annoyed that I missed it.
Well, I think that's so great that you have 75% detection rate as the patient enter the hospital. I don't even think that we have that here. That means that people, like a lot of physicians at your facility or staff there actually recognize delirium.
Yeah, I mean, I think that's been one thing I would say, and it probably is paralleled in Australia, is that I think the country's got on board much more with delirium than it used to. And, you know, I'll probably be tweeting this a few times tonight and tomorrow, but, you know, one thing that's been great is data, as Jim was saying, you know, measuring it, like, and I don't know if you can do this in Australia with national, but, you know, we've got, in England, there's the hospital episode statistics. In Scotland, we've got Public Health Scotland database, and basically all the NHS, so that's population of 70 million, reports all the diagnoses that comes through the hospital that are coded, you know, and Thomas Jackson, who's a deliriumologist and geriatrician in Birmingham, he posted a tweet 2 or 3 years ago, amazing tweet saying, look, the amount of delirium coding in 85 to 89-year-olds has tripled in 3 years. And I thought, oh my God, that's an incredible trend. So I asked him to get more data, and I got the Scottish data. So yeah, we're definitely seeing in older people massive increases in delirium coding, so that in Scotland last year, 15% of 90-year-olds and over had a delirium diagnosis coded. You know, it's not from case, you know, like looking through case notes and extracting it. It's just actually been diagnosed and put into the record, you know, by the system without us having to do it. So, I mean, that's still an underestimate probably, but it's, I think it's beginning to bite, and it really gives me a lot of encouragement that ultimately it will work. You know, the more you teach people, there's just not enough of us doing the dissemination and teaching, but it does work.
Hopefully that's a snowball.
Yeah,
Snowball effect.
How much,
I know Shibley
Heidi, how much time have we got now? Heidi.
We have 8 minutes.
Okay, I would like to quickly come back to Brie's talk. It showed for me the schism of risk in the hospital, the risk about patient safety, where you want zero risk, and the innovation, where actually you need to crack eggs, then make an omelette. It's okay to fail. I thought the talk by Brie was brilliant, actually. I come from the field of dementia. The problems we have in person-centered care, some of our background based on Kitterwood's work, and the person-centered approach is important, but in delirium it's problematic because you are looking for a new normal often with people, and what you don't want is to preserve the patient aspect in how they were, because you need to accommodate to how they're changing. Now, the issues about innovation and patient safety, how do you engage buy-in? Well, of course, one thing is to encourage patient safety, and that if you're looking for poor outcomes to avoid, that is one compelling case, and build up a financial case around that. But the other way to approach it is a value-based approach, looking at outcomes which matter to the patient. And I bring you back to Gideon's excellent talk on outcomes which matter to the carer as well. So in fact, there are lots of ways to measure outcomes in delirium, not just medical ones. And it also embraces how our hospital is organized in the first place and what it thinks its function is. I'll leave it there.
Yeah, I couldn't agree more. I always bring it back to if you had a child in hospital and you're the primary caregiver as a mother or father, for example, you know, you are encouraged to stay there. The room is set up with that spare bed and you get a meal and you get everything else and it's all sorted. But we just don't have the same if the carer wants to come and stay for the patient with delirium and or dementia. And I just think that that's a huge gap when they're just as vulnerable, if not more vulnerable, that, you know, they go, oh, you can kind of sit in the chair next to it, but it's a shared room and you'll have to bring in your own food and you'll have to pay, you know, $50 a day for parking. And it's just that disparity kind of really, you know, stands out to me. And I think that's why it's really important to get that patient and family experience and feedback to say, oh my gosh, it is amazing. And it would just made a difference that we had the sunflower there, or they put me in the lounge room, or they found an extra bed that, you know, a lounge chair that folds out. Just those little things, I think, will start to tell the narrative from that perspective. And I think that actually speaks louder volumes than, you know, the financial side of things.
Yeah, which is actually great. Thanks for reminding me. It's actually very hard to measure that. All the stuff you're talking about is textbook person-centered care from Dawn Brooker, for example, here in Worcester, and how you measure things. Some of this is very hard to measure. And this is the issue about Gideon and collection data and Tru. Some of this stuff is actually impossible to capture. And this is a really big problem, which we have to admit if we're being honest to people.
Yeah, I absolutely agree with that. We do have to admit, I mean, they are very difficult to measure. And I think we have to come up with ways that we can represent them, even if we can't measure them in the same way we measure other things.
Like writing stories,
Yeah.
of things that you find, or what I do a lot in the hospital is sometimes things that we cannot measure by quantity, but the quality, like what did I do with this patient, and how did I improve the care for this patient by doing this? So like writing a short story, but then you have to have the time to do that. So, but that can be captured and put in a journal or something. You know, it's like, for example, we have a patient who's have dementia, and she couldn't verbalize what she needed, and she was crying and screaming. The entire ward can hear her cry, and nobody understand why. And so by walking in that unit, it's like, okay, this patient needed something that we haven't met her need. That's why she's crying. You need to go in there and check on her. And of course, she's need to be changed. But nobody understand that. But can you really measure that? No, it's a story that you can share. So.
Absolutely. So we have 3 minutes left. Is there anyone who wants to ask one final question? Well, I'll sneak one in. I wanted to ask Brie, I'm always like fascinated, and I'm a nurse and I practice, but I think about delirium like 24/7. But how did you get your staff? You said they went from I can't do something about this, if I can't do something about delirium or falls, to I can do something about it. Like how did that go? Like, what do you think the one or two things were?
And giving them that sense of independence, and it's their opportunity to kind of shine, I guess. So we had, outcome measures that we wanted to achieve of increase our screening rate to 80%, reduce falls, increase individualized care plans. So they were our big measures, but how we got there was actually up to the ward. So I think it gave them that sense of control and that they weren't being told what to do. They were developing it themselves. I think that was a big one. And then when they started, knowing that it was okay to fail. So when they started and they used the sunflower or they implemented the top 5, I think they could see that it worked. So they realized that they could do something because they had a quick in with that patient of, tell me about the Richmond Football Club, or, tell me about your dog, or show me this. So they actually felt like they had something they could do. So as soon as it's that snowball effect again, as soon as they realized that just by knowing that she preferred to be called Betty instead of Elizabeth, knowing that if they said, hey, Betty, will you do this, versus hi, Elizabeth, and she didn't respond, it made a huge difference. So I think when they trialed it and could see that it was making a difference, they were more inclined to do it. But it wasn't like from tomorrow, every patient has to have a sunflower filled out. They went on their own journey to get there, and then kind of the penny dropped that, hey, this does work and I can do something. But involving them from the start was the big key thing. It wasn't telling them what to do. It was them kind of coming up with the ideas.
Wow, that's fantastic information. Did they come up with the flower, or was the flower something that brought to them?
We already had the flower, so we had these
Okay.
resources, but it was how they wanted to use it.
Okay, all right.
The flower
Awesome.
comes from Tom Kupfer's work a few decades ago in dementia.
The flower?
Yes, Kupfer's sunflower is documented in Dementia Reconsidered.
Yeah,
Okay.
I think they use the forget me not flower, which is like a blue flower in dementia. It doesn't matter. It's the principles of a getting to know you tool. It doesn't matter what color the petals are or the flower shape of the flower is. But yeah, absolutely, there's another one called the forget me not.
Yeah. I can't believe it, but we're at 6 p.m. or I guess that's 6 p.m. my time. It's morning for all of you, for some of you, and sometimes it's bedtime. So this has been amazing. Thank you so much, Tru and Brie, for sharing.
Thank you very much. I really can't wait to go through the whole thing again and take lots of notes.
Brilliant.
And rush off to my next meeting and say, you got to do this.
Thank
Thank
you so
you so
much.
And everybody
It
for
was
joining.
fun.
Shibley, thank you so
Thank
much.
you.
Bye.
Thank you.
Thank you.
Well done.
Take care.
Bye.